It's more behavior than biological factors. Men will socialize usually in very crowded places. Like I said, they tend to go to places that, you can imagine if today you have a political rally, the bulk of people who will be in that crowd will be men. If you've got a game of football happening between two big teams, the bulk of people, the majority of people who will be crowded in that stadium will be men. If you go to pubs, bars and drinking places, the larger number of people who will be in those places will be men. So those behavioral things are the ones that are probably driving higher rates of TB infection in males than in females. We haven't identified at this moment in time specific factors that make one gets more TB, increase the risk of getting TB in the lung versus getting TB outside the lung. We don't know why that is so. We don't know why some people don't get TB of the lung and they get TB of the brain, or TB of the bone, or TB of the liver, or TB of the intestine, and so on and so forth. We really do not know at this moment in time. That would be a nice research study to try and do and unravel some of those unknowns in the TB field. So extrapulmonary TB basically means TB outside the lung. And TB textbooks will tell you that every organ of the body can be affected except maybe nails and hair. Those are the only two organs in the body that are not affected by TB. Now, how does the doctor know that you have TB of some organ? It begins with the symptoms. Doctors are trained, or other clinicians are trained to be able to identify where the problem is. If you walk into a doctor's office and your problem is headache, and your problem is convulsions, you are having fits, or your problem is you have you can't move a certain part of the body, the doctor will, and maybe you have fevers and you're sweating and you're losing weight, the doctors will want to see how the brain is, and they'll probably do a scan. That could be a CT scan or an MRI scan, whatever scan they do. And that may show characteristic features in the brain that tells them that this is brain TB. Now, brain TB is difficult to diagnose. Usually it's diagnosed not by confirming that there is TB germs in the brain, because it's difficult to sample the brain easily. It will be very complicated to sample everyone with brain TB. But at least based on the symptoms and the characteristic features on the CT scan or MRI scan, the doctor will know this person probably has TB of the brain. And it's the same thing with TB of the bone. It is the same story with TB of the liver, although structures like the liver are much more easily accessible to doctors. They can sample the liver. Urinary TB is the same kind of thing. But urinary TB or genital urinary TB may be a little easier to pick out, because you can check urine, and you can do all sorts of diagnostic tests that help to identify TB in those parts of the world. So in those parts of the body. So in essence, it all depends on how that individual presents and how easy it is to obtain a sample from the part of the lung that has been affected by TB. In some parts it will be very difficult, and therefore the treatment for TB is based on the doctor's best knowledge of the disease, and in some situation attempts can be made to sample the organ that's been affected, and then take those samples to the laboratory to again test for TB, the way you would test sputum samples, for example. So extrapulmonary TB outside the lung is a difficult clinical diagnosis, and there's a tendency for people who have extrapulmonary TB to have their diagnosis delayed. It happens all over the world. It's not a Kenyan thing. This is because the symptoms and signs of TB outside the lung are very non-specific. So you can get fevers for all sorts of reasons. You can lose weight for all sorts of reasons. And if you're presenting, if your first call is a health facility like a dispensary or a health center where you don't have high caliber clinicians to really dissect out what the problems might be, by the time you get to places where there's clinical capacity to be able to think through the diagnosis and consider TB and do the appropriate tests and what have you, it may be quite a long while. This happens all over the place. However, the TB control program in this country and others have made very, very good efforts to try and train and support healthcare workers at all levels, including at the community level, to be able to know when to suspect TB. The focus has been mainly on lung TB or pulmonary TB, and that's why there is a little bit of challenges with diagnosing extrapulmonary TB. However, healthcare workers are being trained to identify people who have TB, irrespective of where that TB is happening. But like I said, the diagnostic capacity is difficult. If I present in a health center that cannot do brain scan or MRI, I am referred to the next level and the next level, and then I have problems. Remember, TB affects mostly poor people, and to be able to move from a dispensary to a level 4 or 5 hospital where my TB will be diagnosed may be difficult. Finding the money and what have you to be able to transport myself to the place where a diagnostic capacity can happen. Even when I get to those places, in this country, unfortunately, one has to pay for the CT scan, one has to pay for the MRI scan. National Health Insurance Fund, which is changing to something else, doesn't cover, and not all of us are registered with it, so on. And so there are many problems. And I think the overall effect of that is that there's a delay in diagnosing extrapulmonary TB. But it's a global phenomenon. It's not a phenomenon peculiar to Kenya. There used to be, but I think now technology has advanced, knowledge has advanced, there's lots of research that has been done. By and large, most people with TB and other so-called comorbidities, HIV, diabetes, chronic kidney disease, can be managed successfully with the current level of, with the current tools that are available. So one shouldn't worry that they have TB and HIV and what would happen to them. Yes, the considerations must be manage both conditions, and depending on the condition that you're dealing with, prioritize which one you want to start with, then go on to the next one, or manage both at the same time. There are many permutations here, and the basic thing is the management of TB and comorbidities must be so-called patient-centered. You need to know what the best thing to do is for that particular individual. And again, healthcare workers in this country and in other parts of the world have been trained to be able to know these things and to be able to offer treatment that is appropriate for people with TB alone or TB with other diseases. So during the evaluation of people who have TB, that evaluation should be holistic. People should know everything about me as a person who is being treated for TB. How old am I? How young am I? Where do I work? Do I smoke? Do I drink alcohol? Do I have food? Don't I have food? These things eventually influence treatment outcomes. And I should have a treatment plan or a care plan. This is not just treatment, it's a care plan that takes into account all those issues, because tuberculosis treatment, unfortunately, is lengthy. Bare minimum 4 months. If with the currently available tools all over the world, bare minimum is 4 months. Most people are treated for 6 months. Some are treated even for longer if they have drug-resistant TB. And therefore, that care plan must take into account every little social, mental, or comorbidities or core diseases that are with that individual, ability to travel from one point to another to come and be supported. Whether in fact I am willing or not willing to have a community healthcare worker to come to my house and to support me, that's called holistic care. And it is a very important part of managing anyone with chronic disease. No one should be given blanket care for everyone. Human beings are very different, and therefore every human being should be evaluated for their peculiar circumstances and be provided a care plan that is fit for their purpose. Now, this is where sometimes the challenges are in terms of programming, public health programming, because you want to do this for people, but there may be limited capacity from the healthcare system to be able to offer that. But there has to be a constant struggle to offer comprehensive or holistic care to people who suffer TB. There are many things that are happening. The research world is abuzz with innovations and work that is being done to try and improve TB diagnostics. Sputum is not a very good tool. A lot of people are not able to provide it, for example. A lot of children find it difficult to provide sputum for TB testing. So people are looking at all sorts of things, including what we call tongue swabs. You swab the tongue and take that to the laboratory and see whether that is going to give you a TB diagnosis. People are looking at breath. You analyze the breath and see whether that breath has a peculiar, they are called volatile organic compounds, VOX, peculiar profiles of these so-called volatile organic compounds that then can tell you that probably inside there, this fellow has TB. People are looking at urine samples as an easier sample to obtain than sputum. People are looking at blood and looking at what we call gene signatures and so on and so forth. So there's a lot of work being done to identify better tools to be able to diagnose TB, including tools that will be useful at the home setting. Today, if I want to know if I am diabetic, I can buy my glucometer, go home, test myself for TB, and if I know what levels mean diabetes, I can tell I'm a diabetic and walk to the healthcare facility and say, Doc, I'm a diabetic, can you treat me? Today, if I want to know if I'm HIV infected, I can buy my kits and test myself at home. That's where we want to take TB. We want to take TB to the same level where people can actually do self-testing at home. I think if you ask me that question, the most important thing is that we should mobilize resources to fight this TB. And I personally believe that there are certain diseases that we shouldn't be happy that we have them. These are diseases of shame. Tuberculosis is one of those. Cholera is one of those. Typhoid is one of those. These are diseases that we should have gotten rid of many years ago, because they actually, you can't go to anywhere in the world and say we have a big problem of TB and be proud that you have a big problem of TB, or go and say you have a big problem of cholera. If you provide people with water, piped water, for example, and sanitation, you get rid of cholera and typhoid. It's the same story with TB. We can test very many people. We can make sure that everyone who is vulnerable for TB is tested for TB. If they do have TB, they are treated for it. If they have TB infection, they are treated for it. And if we did that regularly and consistently, in another 10 or so years, we could have brought this TB down by more than half of the problem right now, if not more. So we can do it, but to be able to do that, we need political commitment and we need to mobilize the resources to be able to do that. Unfortunately for this country, the bulk of the money that we are using for the operations of our TB program, yes, I know we are spending our own money to make sure our TB program officers have salaries, they have water in their offices, they have electricity and so on and so forth. But we are not paying for TB testing, and we have not been paying very well for TB medication. And we need to be able to pay fully for our TB program, to train our healthcare workers, to supervise our healthcare workers, to make sure that the diagnostics are there and the treatment is there. So we need to mobilize sufficient resources to be able to do that. Now, TB does not just happen in isolation. It happens in combination with other things, social factors and other diseases, and we need to have a comprehensive approach to deal with the problem of TB. And that means political commitment, additional resources, and these resources should be domestic as much as they can be. So, like I said, tuberculosis affects both male and females. The consequences are poor for, or rather the consequences of TB are bad for both men and women. But think about that woman. A woman who has TB means the family is all in, from a societal and social point of view, they can't take care of their families, okay? So even if the man in the house, suppose this is a married woman, even if the man in the house provides the food and what have you, but they are very basic things that women tend to do in our societies. They take care of the homes, they're the home builders. It means if the woman is unwell, there's a major problem in terms of how that home runs, okay? And that has consequences. It has got consequences on the man himself, and has got consequences on the woman directly, and has consequences on children and neighbors and everyone else. Two, there are certain forms of TB. So if the woman develops complications of TB and cannot take care of themselves and lifelong, that woman will probably suffer higher degrees of stigma and discrimination. So because they can't take care of themselves, they have a big risk of being TB. There's a big risk of that TB leading to infertility. These are big issues. So women are massively affected by the TB problem. And that's why for us, it is not a question of saying men versus women. It is ensuring that we have a comprehensive package of care for people with TB, irrespective of whether they are men or women, and taking care of all the consequences that can happen in people who have TB, whether they are men or women. Yeah, I mean, the stigma and discrimination and all those things that affect people who have chronic illness, and especially TB, is huge amount of stigma and discrimination, and the provision of care that is not rights-based. You know, I need to know that I have a right to health, I have a right to medicines, I have a right to be treated decently by healthcare workers, and so on and so forth. And these things we know, but a lot of people in the world and a lot of people in TB program don't practice this kind of things. So rights to information, rights to good quality care, rights to receive care in an environment that does not increase my risk of getting other things. All those things are important. So the Global Fund has been a big mover, together with the Stop TB Partnership, has been a big mover of a rights-based approach, and I would actually also add WHO there. They've been big movers of a rights-based approach to the provision of TB care and prevention services. And we shouldn't take these things for granted. There are huge problems of human rights barriers to accessing care and for TB and other services related to the TB problem. So yes, I am fully supportive of a rights-based approach to the provision of services for TB.